Mary Menges is our moderator today. Mary, you want to say hello?
Sure. Hi, everyone. I'm Mary Minges. I'm a licensed clinical psychologist at Montefiore, and my graduate studies were in mechanisms of change. So I am very excited to hear Dr. Smith today speak about his integrative framework for psychotherapy. As a training director here at Montefiore, and being so entrenched in our students' education, I'm very excited by this model. It feels very clear and streamlined, and I can't wait to hear what Dr. Smith has to say.
Terrific. Okay, and Mary, why don't you go around the circle? Help us go around the circle.
Sure, sure. So to my right is Sue Kim. Would you like to say hello?
Hi, I'm Sue Kim. I am almost retiring psychiatrist practicing in the suburban Baltimore, Maryland area.
Uh-huh.
And, I trained a long time ago, and it seems like our practice has changed quite a bit. So, but my main interest is in psychotherapy and healing and process of change and so on. So I am kind of interested in hearing what other people may say about this.
Mm. Mhm.
Wonderful, wonderful. Carlos Velez, would you
Hi,
like to
hi
say hello?
everybody. Yeah, so I'm a psychiatrist in San Antonio, Texas, associate program director for psychotherapy training here. Yeah, just getting started with that position. I've been in the program for a while. I graduated from it. So I kind of sat with the psychotherapy training that we've had. And it's occurred to me recently to kind of revamp and go away from these discrete modalities. Um, so I'm thinking maybe an integrative program might show the way.
Mhm.
If and that's going to be the topic of your presentation. If there's any guidance on how to integrate a residency program's curriculum, that would be great.
Mm, mm.
Excellent. Yeah, are you a member of the Psychotherapy Caucus?
I am, yes.
Okay, we have a group within the caucus. I'm the leader of it, and we have a group within the caucus that's actually working on, I think, an integrative curriculum. And one of the people in that task force is one of the students in my training program, learners. She's a senior psychiatrist. So anyway, I hope that we'll answer some questions for you and make a pathway that's not too hard.
Thank you. Yeah, I'll look for the caucus work group.
Mhm.
I'm in a couple of others, and so it was
Mm,
kind of difficult, but
mm,
yeah, I'll look for yours.
mhm.
So, Barton Blender, would you like to say hello?
Oh, yes. Hi, I'm um, a member of the steering committee. I'm an adult and child psychiatrist, adult and child analyst, and I was a member of the original APA Commission on Psychotherapy almost 25 years ago that evolved
Mm,
into the Committee on Psychotherapy, which was then sunsetted and has evolved into our current caucus of 1,200 members. I have a long commitment to teaching in psychiatric residencies. In recent years, I've been more active at the Psychoanalytic Institute. I'm chairman of research at the New Center for Psychoanalysis. We're involved in an international research project with frequency of sessions and brain imaging and chronic depression, recurrent depression with antecedents and trauma. So we're continuing, to try to open the field. I think we have a big tent in the caucus. I've always been interested, as Jeffrey has for many years, in trying to integrate theory to a foundational psychotherapy. In other words, a psychotherapy that has foundational elements that we can all understand. We can have variations in technique and variations in application and so on. But I think we need a very strong foundation, and to make sure that that foundation is at the core of psychiatric practice. In other words, and that's the hope. That's the hope for the future. Thank you.
Well, it's an honor to have you, Bart. It's very nice. I appreciate your joining us, and I know you have a really broad base of knowledge and a long experience with this. So I really am glad to have you here.
Thank you.
Great. And Christine Adams.
Yes. Hi, everyone. I'm from Louisville, Kentucky, where I've had a 40+ year private practice of only doing psychotherapy with children, adolescents, and adults. I'm also trained in child psychiatry. I'm a member of the Psychotherapy Caucus and work with the mentorship subcommittee on teaching the hungry younger generation who wants to learn all about psychotherapy as if it's a new topic that's coming back. And I have spent the last 40 years studying with my mentor all about Pavlovian emotional conditioning and its creation of psychopathology in people, and am co-author with my mentor of the award-winning book, Living on Automatic, How Emotional Conditioning Shapes Our Lives and Relationships. So I'm always curious about the things that integrate and bring us together under the big tent that can be used to help particularly our younger generation understand the basic elements of psychotherapy, no matter sort of which quirk or division you're practicing in at any one time.
That's terrific. We really have an excellent group of people who are all really pointed in the right direction, I think. So maybe let me just ask you: has everybody looked at the infographic that was offered on the way to signing up for this?
No.
Yes.
Okay.
No, I didn't.
I'm going to go get it.
Okay, well, it's about 9 pages, and it's been vetted by a lot of really smart people. So even though it looks rather informal, it actually has a lot of pretty heavy duty theory packed into it. So do that in your spare time, but it's kind of encapsulates a lot of the substance of what I'm going to be talking about. But let me try. Well, first, let me just share with you kind of how I got to this. I finished residency in 1976 and at a rather psychoanalytically oriented program at Albert Einstein. And shortly after I finished residency, I found myself working with a woman who had been severely sexually traumatized by her schizophrenic mother when she was a little kid. And in my residency, in those days, trauma was considered something for military psychiatrists, and so we had no training at all about it, and so I kind of had to learn from scratch. And what happened really struck me, that when my patient and I finally got access to some very, very traumatic, horrible experiences that she had dreaded ever getting close to. The dread evaporated. They were healed very quickly. They were still horrible experiences, but not things that she dreaded anymore. And but on the other hand, I also noticed that her low self-esteem was much more resistant to change. And it kind of dawned on me that there were more than one mechanism of change going on here. Why did it take so much more work and such a longer time to help her with the low self-esteem that came from her abuse than it did to work with the traumatic events themselves. And that got me really interested in change mechanisms. And that was a long time ago, but I've continued with that interest. And then was I started to teach a course on integrative psychotherapy back in the early 80s, or 2000s, I mean. And anyway, that started to get me oriented towards process rather than methods, and working with alcoholism and different things. Where my original training didn't really apply, I started to find myself wanting to use techniques from a broader range of places, and so as I understood more about change processes, then my approach to psychotherapy, kind of without even thinking about it, changed. I started to focus more on process rather than method, because what I had been taught is apply the method, and after a while things are going to get better. And then in the more recently, I began to become aware of neurophysiology that had been going on since the turn of the 21st century, really, that explains a lot of how change actually occurs. And so putting all of that together has gotten me to where I am at this point. However, let's see. I'm gonna do a screen share here and hope that this all works. Let's see. There we go. Okay. Can you see the slide on your screen? Is
Yeah.
it
Yes,
okay?
yes,
Good.
it's there.
And you can see the big hand pointer?
Yeah.
Great. Okay.
Yes.
Excellent. All right. So, so I like this metaphor of the tree. The branches and all of those leaves represent to me all of the beautiful theories that people have developed, and the techniques and everything. And if we're going to have a framework that's of any use in teaching as time goes on, it's going to need to embrace those things and support them, and not just be another theory or another approach to psychotherapy. And what gives us an opportunity to do that is the fact that over the years, since the 1890s, when psychotherapy first as a profession kind of was invented, nobody has really understood how it works. And so that vacuum creates an opportunity, because if we presume that all therapies pretty much use the same mechanisms, have the same infrastructure, but we just didn't know what it is, if we can fill in that infrastructure, then we have a way of describing what's universal about all the different therapies and pulling them together under one roof. It's gives us a kind of a Rosetta Stone that makes different therapies make sense. And so I'm going to go through with you a way of arriving at this framework that I think will take it step by step and maybe make some more sense for you. And so we're going to look at 5 steps, 1, 2, 3, 4, and 5, that'll get us to a theory. And this is different from common factors. When I say the common infrastructure of psychotherapy, a lot of people say, oh, you mean common factors that Norcross has promoted and other people. But those common factors have a problem, because they're not explanatory. They're correlations, but they're not explanations. And so the first step here is to do something really radical. I don't know, Bart, maybe you know, but I don't know of anybody who has really asked the question of what is it that psychotherapy aims exactly to treat? It's sort of assumed that we're going to treat DSM diagnoses or something like that. But the fact that DSM diagnoses are mixtures of different symptoms really makes it hard to home in on how the therapy might actually be working, unless we can get a clearer picture of exactly what it is we're treating. Bart, do you want to comment?
Yes, Jeff, if I might, very briefly, the work by Charles Nemiroff in the past 5-6 years, it could be more, that showed that for recurrent depression with a history of adversity in childhood, that psychotherapy appeared to be the combined treatment of pharmacotherapy and psychotherapy was clearly more effective. And then when they did the statistics and factored everything, it was felt that the psychotherapy was essential. That's one of the only areas that I know of, where there have been
Oops, I think we lost you.
Yes, I'm sorry, I went off the internet. That's one of the really best studies that I know of, where psychotherapy has been considered essential and important.
Yeah. Well, so let's go ahead and do this radical thing and ask the question of what is it we're treating, and some of my own work and some collaboration with other people within SEPI, the Society for the Exploration of Psychotherapy Integration, have come up with a very simple definition of what we treat. It's entrenched maladaptive patterns. That seems pretty obvious, but if we look at them, it actually is a way that you can describe a huge range of different problems, all the way from attachment problems and character problems to Oedipus complexes and addictions. They all represent patterns of behavior or response that get us in trouble, that are maladaptive. And for the purposes of psychotherapy, we only really work with people, people before they come to us have already tried talking to family members and reading self-help books and things like that. And so we're dealing with patterns that are entrenched. There's some reason why they're stuck there. So that's a characteristic that these things have in common. And they're also patterns that are liable to recur. And so it makes sense to call them patterns, to think of them as patterns. So entrenched maladaptive patterns, this is the only acronym that I will even suggest that you think of, EMP, and that is a way of describing all the things that psychotherapy aims to treat primarily. We don't aim primarily to change people's biology. We don't aim primarily to change their epigenetics, even though that may happen. And so that narrows down our focus a lot. And once we do that, then we can do a lot better to try to say, well, is there more? Are there more common characteristics that all of these subunits of pathology have in common? And the answer is yes, there are more common characteristics. So one is, since the 21st century, we now know that information in the mind, in the brain, is encoded in neural networks, and those are defined by synapses that make certain neurons tend to fire together as a group. And we also, so that's interesting, because if we want to change them, then we're going to have to change some of those synapses, and that's interesting. And of course, how do we get there? We probably do through learning, much as Pavlov described it. And so there's more to say about learning, but that's a fundamental aspect of this. So these things, these patterns are encoded someplace in memory. What else do they have in common? Well, in looking very carefully at them, almost all of the patterns of pathology that we have, even though people may feel that they're doing something positive, they generally are fueled by some sort of dread, some sort of negative emotion, some sort of pain or lack or something that was missing. Even in the cases of addictions, say, where people may say that they're addicted because it feels good, the more you go back, the more likely you are to find that the addiction is really treating some sort of a threat. And so that's something that is pretty much all of these problems have in common. Um, and so that's a glimpse of them. They all do involve then some sort of pattern of how the mind processes the information that's coming in from inside and from outside to determine that there's a threat there. And then the mind goes to work and figures out some sort of a way of responding that's going to take away that threat or diminish the concern that the person has. So we've got a pattern of appraisal, a pattern of response, and in the middle between them, there's some kind of deep limbic emotion, the kinds of emotions that actually motivate us to respond. And that's where the mind identifies things that are a threat. So this is kind of a basic functional neurophysiology that all of these problems that we're trying to treat have in common. So that's step 2 then. What are the common characteristics? So are you with me so far? Any questions? All right, everybody's a little quiet. I'd rather you be more rambunctious, but yeah.
Jeff, the only thing I think I shared with you, one or two things. One term that's used in psychoanalytic theory is habitual modes of response.
Mm-hmm.
You're using the entrenched maladaptive patterns.
Mm-hmm.
So habitual mode of response in terms of behavior, relationships, activities, and so on.
Mm-hmm.
The other thing, in addition to maladaptive,
Mm-hmm.
I would add non-error correcting. In other words, maladaptive, maybe that is encompassed in the word maladaptive. In other words, so maladaptive, repetitive, non-error correcting.
Mm-hmm.
Those are the two. So the repetitive, non-error correcting are two components I would add. Okay, sorry.
Yes. So thank you for that. Something about language. So I'm being very careful here. I don't want to step on anybody's toes, and I want to leave the door wide open for our cognitive behavioral colleagues to embrace this sort of thing. And so I'm a little bit anxious about using language or concepts that have deep psychoanalytic roots. And also want to use plain language as much as possible. Maladaptive has an implication, though. Maladaptive means that these things started out as the mind in some way, energized by our evolutionary history, that they are means of adaptation. And I think that's a little broader habit in my mind anyway. You know, some things like attachment patterns, it's hard to call those habit. Maybe if you stretch it, but the things we normally think of as habits is things that have to do with conscious decision making, where you just make the same decision every time as a matter of course without thinking about it. So anyway, we could argue about those things, but that's the reasoning behind using a fresh term is that I want it to be accessible to everybody and offensive to nobody.
Right. Well, I think the word entrenched implies repetitive, so I feel okay.
Mm-hmm.
I think that's okay. I think the habitual mode of behaving and relating also encompasses so-called defenses and other kinds of behavior, which in and of themselves are a mode of behavior, which is a little different than the actual behavior itself. So
again, I want to be as broad as possible, and so a pattern or a mode. Good. We can quibble, but I think the whole idea really is that we want to find a framework that that a broad range of people can embrace and can make use of easily without having to stretch their minds any further than necessary.
I have a question.
Please.
I just want to make sure I'm understanding this.
Mhm.
The common characteristics are encoded by emotions, dread, anxiety, etc., in the feeling that you're dealing with a threat. Do I understand that correctly?
I think that's a common denominator for pretty much essentially all of the things that we try to help people change.
Why a threat? Why a threat? I'm not getting that part.
Well, if you dig deep enough into whatever pathology you might be thinking of, I think you're going to find deep down at the core of it, I think you're going to find something that was perceived as a threat.
A threat to what?
To the individual, or to society, or a threat that is left over from evolution. And so there are many, many different kinds of threats that are, and some of them I think are built into our biology and sort of the operating system of the mind. Other things are learned. But for example, insecure attachment. Well, why do people have insecure attachment? At least it looks like most of those patterns, like avoidant attachment, is a way of keeping away from the pain of trying to attach when the other person isn't able to connect.
Okay. I'll think about that some more.
Mhm.
It's intriguing. It's an intriguing
Well,
part of the equation.
yeah, I've
Right.
vetted this myself and with a number of other people quite extensively, and we find it a very useful and an interesting way to conceptualize things, even though sometimes it's not obvious on the surface. You know, like for example, addictions are often you can think of them as chronic ways to cope with deep psychic pain that the person may not even be conscious of.
Yep.
The essential um, aspect here is that we're not dealing with feelings that are always conscious. These are the deep kind of limbic feelings that we know on the surface as therapists. We recognize them because they're affects. Affects are conscious feelings plus some sort of bodily change, like movement or tears or hair standing on end. There's something in addition to just pure feeling that tells us this is something that's coming from pretty deep in our being. And those are the kinds of emotions, those deep limbic emotions are the ones that have the motivating power to drive the various kinds of maladaptive patterns as well as adaptive patterns. Okay, well, let's go to the fourth step let's see, one, two, no, now we're on three, is change mechanism. So if we have these information that's encoded in neural networks, both governing the way we interpret things that are coming into our senses or that are internal, and the way we respond to them, how do we change those patterns? Well, it turns out that first we'll talk about learning, that some of what we do in psychotherapy is expose people to new ways of responding to things, and so they may learn something that they didn't know before. But when we're dealing with entrenched maladaptive patterns that are pre-existing and are repetitive, then we're going to have to change some of those synapses around. And so it becomes relevant to ask, well, how do words spoken in a session and how do interpersonal relational events in a session, how do those produce change? And so at that point, it turns out since about the year 2000 that neurophysiologists have done a really great job of at least beginning to elucidate and to clarify exactly how events can change those patterns of synapses. And so, are you all, how much, is anybody not familiar with the mechanisms of extinction and of memory reconsolidation? So maybe I should say just a little teeny bit about those. So it turns out the extinction was identified by Pavlov, and it's, if there's a let's say an army veteran who has a startle reaction every time there's a loud noise, the technique of prolonged exposure says that if you reactivate that startle mechanism by a loud noise, but do it in a context that's really safe and comfortable and everything's okay, eventually the person stops responding that way. Well, it turns out the neurophysiology is that the cortex learns that the war is over, it's safe, you don't have to be startled, it's really okay, relax about it. And the neurophysiology is that what happens is the cortex sends inhibitory signals into the midbrain and blocks the expression of the fear response. It
Yes.
doesn't block the response itself. The amygdala still lights up on scans, but the response to it is inhibited. Yes.
Yeah, I was going to say, Jeff, one of the early pioneers in psychotherapy of that idea, I mean, aside from Pavlovian reward and operant conditioning, was Wolpe,
Mm-hmm.
W-O-L.
Right.
He was, and I don't think he's given the credit today that he really should be given.
He's quite revered in behavioral circles. Yes.
Very, very much revered, and I revere him. I knew him personally,
Ooh.
even as a psychoanalyst, but I revere him great. The other person who's working now in facilitation and extinction at the very borderline of our advanced progress is Amit Etkin at Stanford, and so who worked Handel. So there's still work in the area of facilitating extinction in neuroscience. Okay, just
absolutely. Well, the extinction, there's one problem with it, and that is that extinction is not permanent.
That's true.
If it's not reinforced periodically, then the old fear comes back because the midbrain areas where those deep emotions were being activated, that hasn't changed. And so, but it turns out that there's another foundational change mechanism that actually is permanent. And that's the one that's called memory reconsolidation. And to put it in a nutshell, what happens is when the original pattern of the neural networks that represent that original pattern are in a state of activation, and there's new information that the person is exposed to that comes in and creates what's called a prediction error, then for a period of a few hours after that, the new information can reprogram those neural networks in such a way that the old information is forgotten, is gone, is erased. And there's debate about how complete that may be. It does seem clear with animals and in experimental situations that the activation of the old pattern has to be pretty vivid for this to take place. But once it happens, then the change is permanent and does not require any further effort.
Right,
and pretty remarkable.
Yes, I would comment here to give credit where credit is due. Early naturalistic observers, psychologists, who did not know the neuroscience. Right, exactly. But were brilliant in their observation. One is Leon Festinger, I'll mention that name, who came up with the idea of cognitive dissonance as an important step toward learning. So what you're saying is we need a dissonant situation
Mm-hmm.
to stimulate change. And some of his early experiments
Mm-hmm.
were in that area. And I think that is very important.
Right.
And
Well, you're.
the other is the concept of constructivism,
Mm-hmm.
which means that there has to be some change in the CNS for enduring change to occur. And we now know with the you're telling us with the neuroscience what that may be.
Right. So now we've moved into the fourth step in this process, where we're looking now at. We talked about the two different mechanisms for for modifying pre-existing patterns, and we're also moving into saying, well, okay, what are the conditions that make those things happen? Well, on the one hand, there's activation of the original pattern, and at least if you look at it from the standpoint of memory reconsolidation, that needs to be pretty vivid and visceral, and at the same time, exposure to dissonant new information that's creating this kind of collision. And those are the conditions that make these two mechanisms happen. Now, if you'll notice, I just described something rather peculiar, which is that the conditions for extinction and the conditions for memory reconsolidation are pretty much the same. So there's a little bit of research now that says that if the exposure is repetitive, happens over and over again, then you get into the territory where the mechanism of extinction dominates. But if there's just one or two or three times that the old pattern is vividly activated, then the mechanism is more likely to be memory reconsolidation. So with that sets us up to go to step 5, which is really the cool one about all of this, which is what you were saying, Bart, that once you look precisely at what are the conditions that make change possible, and you ask yourself, do the various therapies we know about, have those therapies instinctively groped their way to finding how to create those conditions? The answer is yes. And the answer is yes, we can pretty much find it. We can find in any therapy that you can describe how it goes to work in some ways to create those two conditions. Maybe to my mind, one of the ones that's the clearest of all. I think there are many, and there are many people who deserve a lot of credit for having somehow intuitively figured this out.
Right.
But it's Alexander and French with their
Right.
idea of the corrective emotional experience.
Yes.
Yeah, and they talk about how when a patient in therapy has gets into a situation where they're expecting a certain response from the therapist, like the therapist is going to be judgmental or criticize me or throw me out of treatment, and then the therapist doesn't do that, it creates this prediction error, and those are the conditions that allow either or both memory reconsolidation and extinction to take place. Another place where the correspondence is actually rather dramatic and interesting is mindfulness. If you think about mindfulness, which there are many therapies now that are quote mindfulness based. What is mindfulness? Well, mindfulness consists of a combination of an experience of the experiencing self and an observing self being in consciousness at the same time. And that's yet another version of this same thing. It's when there's a perspective on the situation and the instinctive experience of it are activated at the same time. We have the same juxtaposition of the original pattern and something that changes its meaning, changes its impact. So we have yet another version of the same thing. what I will say, and this is from my own experience as a therapist, is that when I'm thinking, okay, now what I need to do is I need to help this person get in touch in a visceral, real sense with whatever it is they were dreading and defending themselves against, and at the same time do that in a context that's either experientially safe and comfortable, or where there's new information, like somebody who carries the idea that I'm only lovable if I'm perfect. And that's a more cognitive awareness that might come, that might contradict that, and say that no, it's perfectly okay to be imperfect. You're still lovable. Or maybe that's experiential and cognitive at the same time. But anyway, the point is that the more I'm aware of how I'm trying to produce, to activate the original pattern, and simultaneously to bring in what I like to call the antidote, the information that changes that perception, that experience at the same time. If I have a specific awareness that that's what I'm trying to do, I'm getting to be a better therapist, and I have a wider selection of techniques to bring to bear on it. Maybe I'm going to want to do a two-chair exercise, or maybe just exploration with words, or even take a page out of exposure therapy, and ask the person to imagine something with a powerful sensory aspect to it. So I think that this is how I see this, a framework like this, where we're aware of the common infrastructure, as a way to actually improve and sharpen the way we understand the various therapies and conceptualizations that we all learned. So with that, I'm going to stop for a little bit and see what questions or thoughts you might have.
I'm thinking about this what condition leads to change question that you've posed and spoken to, and I'm thinking about you know patients that I have, say, particularly with panic disorder, or really strong anxiety symptoms, where there seem, they're cognitively experiencing something different than what they perceive as a threat, like constantly. Like, I have this one patient who's afraid to ask a question at work,
Mhm.
and no matter how many times he asks a question and there's no negative fallback, it doesn't correct for him.
Mhm.
And so I'm just kind of thinking, with this framework, what is the condition that would allow this um, error prediction
Mhm.
to correct or help change
Mhm.
this intense perception of threat?
I think there's a couple of layers there. So this is one where anxiety really has to do with people's individual biology, and with how evolution has kind of programmed our mind to function to keep us out of trouble. And so it's not one of the things that's maybe primarily learned, though some people, there clearly is some learning aspect to it as well. I think that we owe a lot to the cognitive behavioral tradition here, to have clarified that, at least in the short run, we seem to do the best with helping people to learn to tolerate anxiety rather than to try to get rid of it. The natural instinct of everybody is, if I feel anxious, I don't want to feel that way, and so I want to do something. I want to take a pill, I want to run away, or confine myself to the house, or go through a ritual in order to not feel that anxiety. And the thrust of most modern treatments, psychotherapeutic treatment for that, is to introduce in a mindful way that the concept where your natural instinct, your biological mind says, "Oh my God, this is the end of the world. I'm freaking out. I've got to do something to get rid of this feeling." The antidote is the idea that, well, anxiety is part of life. It's sort of like body odor. It's something that we all have a certain amount of. We need it. If we don't have any, we're in trouble. And yet sometimes it's really uncomfortable. But what helps the most for people psychotherapeutically with anxiety is to realize that it can be tolerated, that it's
Yes.
something that you can sit with, you can let it happen, and you can mindfully say, "Oh yes, that's my biology that's signaling to me that something terrible is going to happen." And actually, the truth is nothing terrible is going to happen right now.
Right. Jeff, once again, to give credit, Freud's volume on civilization and its discontents, where he says, that at some level, we have to tolerate some of the restrictions, some of the uneasiness imposed, by the work situation,
Mhm.
and so on. So what he called vicissitudes, tolerating, certain, certain vicissitudes. The
Mhm.
other is work by Cloninger, a wonderful personality researcher who looked into traits,
Mhm.
the genetics of personality and types.
Mhm.
Two sort of genetic types.
Mhm.
One is reward seeking, and the other is harm avoidance.
Mhm.
So we have to watch out that we're not not totally into those two things, because they can lead to addiction and so on. In other words, avoiding just all reward, all pleasure,
Mhm.
or avoidance of any kind of discomfort. In
Mhm.
other words, so what you're saying is there's some sort of basic ground level of
Mhm.
restriction and discomfort that we have to tolerate, and we can't have a reward and totally harm avoidance life.
Right. Absolutely. Now, there's another layer, and this is one where the psychodynamics comes in a little bit more. One thing I like to think of is with the question of, well, cognitive behavioral is so different from psychodynamic, and how can the two of them exist in the same framework? Well, if you look at the cognitive behavioral literature, and you ask, where do automatic thoughts come from? Because cognitive behavioral therapy is all about people's responses to their automatic thoughts. And usually the answer is, well, they're learned. And I would argue, from having listened especially to alcoholics in early recovery, and if you listen to their thoughts, like, well, maybe I'm really not an alcoholic, or gee, I'd like to go visit Joe. He's an old friend, and I'm sure he's going to respect my sobriety. And so let me just go and hang out with him. And those thoughts are, to my mind, created on the spot and exquisitely crafted to lead that person to a relapse, because somehow their mind thinks that that's what's good for the individual and good for the species.
Mhm.
So, in any case, if you ask a CBT person, where do these thoughts come from and why are they there, they're probably going to tell you they were learned sometime, and they just waft up spontaneously from the memory bank someplace. I would say no, they are purposeful, they are adaptive or maladaptive, and they are part of an entrenched maladaptive pattern. Those thoughts come up with, in effect, probably the purpose of influencing our conscious decisions. And so, who knows about that? Well, psychodynamics does. People have been studying, why do people have this particular automatic thought rather than another one, for many years, and they know a whole lot about that. And so I would think that our CBT people know a whole lot about how people respond to their automatic thoughts, and psychodynamic people know a whole lot about what's behind those thoughts in the first place. And why not pool those things together? Why can't we all work under one roof? Just to go back to the anxiety question, so I think there's another layer in a way of looking at anxiety, which is to say, why is this person to have this particular anxiety? And often enough, there's an answer there. I'm thinking of a war veteran who has intense anxiety, and it's taken quite a long time to be really clear that what he's afraid of, there really is something behind that anxiety. What he's afraid of is his own anger. He's afraid that his own anger could cause some kind of destructiveness that he would terribly regret. And so now that we've explored that and we have some idea of what's behind the anxiety, then we have a whole nother way of approaching it and being of help. But that's a longer term thing. It's not a 12 session kind of operation. So I do think that anxiety, very often there are two approaches to it. You know, there's the mindfulness approach, and then there's the psychodynamic approach.
You know, I would say with my work on emotional conditioning that what I've discovered is that the maladaptive emotion is conditioned into the child at an early age.
Mm-hmm.
And later on, an elaboration of a cognitive reason as to why
Mm-hmm.
it's created.
Mm-hmm.
I mean, I found it in that sequence. I don't find the CBT part of it that the automatic thought just springs from the person as a sign of their pathology,
Mm-hmm.
but more like what you say,
Mm-hmm.
it's created, it's crafted
Mhm.
after the fact in an effort to explain the aberrant emotional conditioning that makes a person feel a certain way.
Yes. Yes. And I think that's, I do very much agree with you. And what I really like to hear is a developmental point of view, because I think very often it's terribly useful to listen to kind of the developmental level from which units of pathology come, and they have a particular style that maybe is reminiscent of a certain era of development, and it may be more kind of nonverbal and instinctive, or maybe more cognitive, or on a layer that's actually conscious. So there are many different ways that these things are manifested, and I think it's very valuable for us to recognize that things may start out in one place and evolve and involve, you know, different points in development and different levels of
Yeah.
cognition.
Jeff, I think that was very well stated. I think one way to sort of put that as a something in the back of a one-liner in the back of the brain would be that certain preconditions are more favorable toward the stamping in or encoding of trauma of non-adaptive situations.
Mm-hmm.
One would be certain critical periods in childhood and development,
Mm-hmm.
critical periods, and then the other would be
Mm-hmm.
intensive traumatic exposure. So adversities, in other words, there's something about adversities that gives a message to the brain: you better not forget these, better be prepared, better be hyper alert for these in the future. And part of that, to get back to the encoding and so on, part of it is maladaptive, yet part of it ironically is adaptive in the sense, of safety or something like that.
Right. I mean, we all see how almost every pathology or every adaptation that we see that may be maladaptive in many ways also has produced other strengths. That, you know, most of the time, I think it's rare to find somebody whose problems don't have another side, the other side of the coin, where there's some hyper development, some hyper growth that actually turns out to be useful.
Right. And, in a way, that's sort of a counterintuitive. For instance, some evolutionary biologists have said it with some seriousness and some tongue in cheek that,
Mhm.
well, why has depression as a genetic tendency, why has depression survived all through
Mhm.
evolution if it's so maladaptive, it leads to
Mhm.
self-annihilatory, self-destructive? Well, one thought was, well, while the other cavemen were out hunting dinosaurs, getting stomped on by the dinosaurs, the depressed person was withdrawn and in the cave
Yeah,
and not out there. So
yeah. Um, Very much so. So I think I want to say how much I appreciate, Bart. I think you're illustrating one of the things about this framework, which is that it really has room to honor the many incredibly intuitive and bright and thoughtful people who've formed our field, and how much it would be just wonderful for us to be able to honor, to quit fighting amongst ourselves, to
right.
quit the silly competition between one therapy and another in the horse races, and be able to take this whole legacy that we have, which is unbelievably rich, and recognize it for what it is. So that's why a big part of the thrust of what my own writing and thinking has been about is um, to uh, to do this in a way that doesn't step on anybody's toes. And because there's been such a gap in understanding how therapy works, that makes it relatively easy to do. Because there's been so little work on really the ground level details of how words and relationship can bring about change.
I have a
Absolutely.
question about treatment.
Mm.
Is one of the goals of treatment just to correct things in the relationship, or is it also to teach the patient how to continue correcting these things after
Mhm.
treatment ends in
Uh,
themselves?
Yes. So two answers to that one. Absolutely, absolutely, absolutely. So one is, if you read the infographic, it talks about three mechanisms of change. The first one is learning, is new learning, and I think that's a very essential thing, both because people may not have been exposed to healthy things like sharing feelings, and also because maladaptive patterns often block out our awareness of aspects of life that would really be valuable to be more knowledgeable about, more aware of, more exposed to. So I think that continuing to develop and acquiring new experiences and new knowledge. I have a very simple idea about development. I think development really happens when you try out new things, when you try out new behaviors or new ideas, and go through whatever discomfort there might be in the process of learning, and then you've acquired some new ego strengths that you didn't have before. And that, in my practice, that's a huge part of what I do, is to try to support that. I'm going to go to another slide here, actually. Um, so so this is what happens when we put the common infrastructure into place. We have a bridge between all of these different orientations of psychotherapy. This one I could go to, but I'm not going to right now. But while we've talked about the three mechanisms of change that are now understood from a neurophysiological point of view, activation of the old pattern with affect, activation of a new knowledge, and that is what I like to call the antidote, and new learning. But that's not all that therapy does. I think we need to be aware that there are some facilitative factors, there's some conditions, and at any given time we may be working on one of those rather than one of these three sort of foundational change mechanisms. One is regulation of arousal, because when people are dysregulated or hyper aroused or even under aroused, we're not going to be very successful with our therapy. Another one that some therapies, like especially psychoanalysis, doesn't really talk about supporting people's motivation, but the truth is we all do it. And in other therapies, it's more openly recognized. We do lots of things. We talk to people about how things used to be and how they've grown. We talk about where they might be going in their therapy and generate some hope, some belief that this is a positive thing. So supporting motivation is something that is a regular part of our therapeutic activities. And also, we need to not forget safety and informed consent. There, just in my blog that I've had for the last 10 years, there have just been too many stories of therapeutic disasters, and really um, places where people were shocked with things that they hadn't anticipated and they weren't told about. And finally, the sort of what I think of as the Swiss Army knife of psychotherapy is the having a positive therapeutic relationship, and that contributes to every one of these change mechanisms and contributes to each of these facilitative factors. So that's just to give a more complete picture of, if we look at this whole infrastructure, we also need these four facilitative elements, and not to set those aside as well. And so I didn't want to miss out on those. So we have 15 minutes more that we set aside. Are there other questions?
I'll chime in. I really appreciate this framework. So I'm less familiar with, and I'm hearing maybe some common points with this. I'm less familiar with the cognitive behavioral therapy than I am with the psychodynamic theory. But the more I hear about it, I mean, so I felt like part of my job as a new director for therapy training was to sit in everybody's classes. And the more I've done that, the more I begin to hear, I suspect, but I don't know yet, that there's more in common than there are differences. Just the example that you gave, and in terms of learning things over time, and the automatic thoughts that come from it. When I've listened to cognitive behavioral therapy talk about the origin for the automatic thoughts, it gets back to these sort of intermediate, I forget how they call it, but it gets back to these core schemas. These things that come from possibly childhood, which is where we all tend to look when we're in a psychodynamic frame of reference. And yet the cognitive behavioral therapist doesn't seem to talk about the unconscious at all. It's rather, I think they would say it's out of awareness. That seems like the same thing. So I just find that really interesting.
I like to talk about, again, using language that's non-denominational. I like to talk about the non-conscious problem solver, and to point out what we now know from neurophysiology is that something in the order of 95% of the activity of the mind goes on outside of consciousness, and the dividing line between what's conscious and what's not conscious is a rather kind of a flimsy curtain that some things are are imposed on our consciousness, and some things we can kind of make an effort to be more aware of, and so there's a certain border area of consciousness. But I think that knowing that neurophysiology, that 95% of this activity is going on outside of consciousness, you can see that the CBT world is little by little moving in our direction, in a broader direction. The idea of formulation has taken hold to a certain extent in the CBT world, where at some time, Watson said, if you can't measure it, then it's not scientific, and so ignore it. But that's been eroded a lot. And there's even a book by, what's the Irish guy? Darn, I don't have the name, but a book on resistance in cognitive behavioral therapy. And he doesn't quite identify psychodynamic factors as causing resistance, but at least the phenomenon has been identified. And I think that many actual practitioners who have been trained in CBT therapy just can't help but get curious about how come these things are happening, or how did this develop.
Yeah.
Yeah, there's one other thing that I was talking with Mary about, that I think it's an area that I don't always mention because it's complex, and it's not fashionable, and that is what cognitive people call core values. And the way I think about it, our values are part of an internalized self-control system that animals don't have, where the alpha dog spends a lot of energy keeping the whole pack in line. Human beings have our own internalized system that does the same thing. When we're doing things that are not good for society, we feel shame or guilt. And when we are doing things that are lined up with our culture, then we feel pride. And that's part of a rather discrete system. And interestingly, the emotions of pride and guilt and shame do not originate in the limbic system. They start out in the cortex someplace. And I think they wind up in the limbic system because they have such motivational power to get us to do things or to not do things. And so I think of this as a whole system. And if you look in the literature about the superego or the conscience, there's almost nothing there since the 60s. I think it's because sin became unfashionable back then, and everything is okay and it's all relative. and so there's very little literature on that, but I would bet that if you started to do some research, that you would find that the internalized values that generate pride or shame or guilt are actually harder to change than other mental contents. They're either guarded in a different way, or they're structurally different. And so I think that changing core values, to me, is a more challenging aspect of psychotherapy than any other. And I think it would be marvelous to have some research on that. But
Well, that's
yeah. Go ahead.
yeah, Jeff. Once again, we have pioneers in that
Yeah.
area. Actually, there is a fairly large psychoanalytic literature on shame, in the last 30, 40 years. But of course, it's couched in the analytic vocabulary and jargon. But in a simplistic way, we would say that shame is the distance between your current self-evaluation and what we call your ego ideal, or your super core value. Like, how far distant are you from that? And the more distant you are, the more there's a feeling of shame, and the more you merge with it, the more you have a feeling of euphoria and self-fulfillment. And I think you're right. I think that is a component that often is not addressed. We often run to addressing,
Well,
to
there's a
right,
place,
to
Mark.
addressing symptoms.
Yeah, there's a place where that thinking is really good for your run-of-the-mill patient. But the place where I first got alerted to it was different. It was from the same patient I mentioned earlier, where the self-esteem, the attitude of low self-esteem was much, much harder to change. And
Yes.
when I looked really carefully at where it came from, it wasn't really her idea of herself. It wasn't that. It was specifically internalized through a mechanism of identification with the aggressor, of identification with the attitude of the person who abused her towards her.
Uh,
And I think that identification has a purpose, but it's a very specific core value that is at odds with other core values and yet has a powerful effect on the person's life. And
yeah.
so I think when you look at those cases, then conceptually it becomes valuable to say that there are specific internalized values that can be pathological, and that changing those really is a goal of
Right.
therapy, and
Right.
something where
Right.
and so
Right.
when I
And no,
talk about
you're right.
yeah, when I talk about research, I'm
Yeah.
really thinking about trying to understand better the neural pathways and the neurophysiology, and what exactly is it that makes that change process different and distinct from,
Right.
let's say, not being afraid of something that you used to be afraid of.
Right. I'd like to also give credit, if we
Mm.
go back to where do automatic thoughts
Mm-hmm.
come from, in addition to childhood adversities and traumatic situations, Piaget
Mm-hmm.
came about 30 years ago and lectured to the American Psychoanalytic
Mm-hmm.
Association to keep your eyes open with regard to development. So, in other words, there's a cognitive epistemology of development,
Mm-hmm.
not only what goes up and down, or what goes round and round, or
Mm-hmm.
what is an object, but there's a cognitive epistemology of the way, what we call attributions.
Mm-hmm.
Who is doing what to whom, and so a lot of the automatic thoughts come from causal misattributions
Mm-hmm.
in childhood, not fully understanding what people are doing to each other, not fully understanding a certain human event that
Mm-hmm.
occurred in front of your eyes,
Mm-hmm.
between your parents or to you, and then that is not that is not understood, and
Mm-hmm.
it's carried on
Mm-hmm.
as a schematic memory, and
So true.
right, this is the way people relate to each other, and
Yes. Well, let me give you two clinical tidbits that are right in line with what you said, Bart. And by the way, I don't mention all the wonderful people who've I've learned from in arriving at this way of thinking, because I'm trying to do something that's fresh and simple and doesn't step on any toes. But in fact, every piece of it owes a lot to a lot of people,
Robert,
and that's the beauty of this, is that it is supportive and compatible with all of those views. So the two tidbits are these. One is it's been extremely valuable to me to realize how often the non-conscious problem solver, as I like to call it, or the little kid inside, has a different way of solving problems from adults, and how many of our
okay,
patients find themselves trying to solve problems in a childlike
exactly.
way. So children, when they have a serious problem, don't even think about how to solve it, because they know that the ones who need to solve it are the grown-ups. And so their job is to motivate the grown-ups to solve the problem. And we as therapists often turn out to be the grown-up that inherits that responsibility. And I find that a very valuable way to look at transference, when you get the feeling that your patient is somehow waiting for you to do something or to fix something, and you know that you can't really fix it because it's something that, anyway. So that's one tidbit, and the other one is, it comes at a little bit particular area of development where I think often children get stuck on, is it my fault or is it the grown-up's fault? And they don't want to blame the grown-up. And it's easier to blame themselves, but they also know that they're really not responsible. And so we get in adult patients a kind of back and forth between it's my fault, it's their fault, it's my fault, it's their fault. And the cognitive piece in there is that children, as Freud pointed out, don't have a way of conceptualizing nothing. And so the concept of it's just one of those things doesn't compute for kids. It's got to be my fault or it's your fault. It's one of these.
You're right, exactly.
Exactly. And in the same way that if you try to tell a child that there are no monsters, it doesn't compute. You're going to have to say, no, the monsters are far away, or I'm going to beat them up if they come here. But if you tell them they don't exist, that just doesn't compute up until a certain age. So I think Piaget, we owe a lot to Piaget, we owe a lot to Freud. And I appreciate your pointing out some of these antecedents of the really impressive amount of knowledge that has been gathered in our field, and and that we need to again to quit fighting and begin to pool together this broad range of valuable information that's been given to us.
Yes, and one of the great steps of Aaron Beck during his years when he was thrown out of the Analytics Society and wended his own way, and I was there at Penn at the time. What we understand today is that whereas my colleagues were sitting back and interpreting, well, I think you did this, and I think this is your thought, and I think what he said is, I want to know what we call epistemic authenticity. I want to know what your depressive thoughts are. And he listened and understood these thoughts.
So Aaron Beck understood that you have to activate the maladaptive pattern.
Exactly.
You have to make it real. And the analysts sometimes knew that, maybe sometimes didn't, but tend to have that come up in the course of the transference. If you wait long enough, transference heats up, and then you've got activation of old patterns. So there are different ways to have it happen.
Right, or overinterpret, or rather than empathically understand. Right.
Yep.
Another thing that I do
let me just say that our official time is over. Anybody who wants to leave, you're welcome to do it. I'm open to a few comments from you before we close up.
Right. Well, Jeff, maybe in the future we'll say that Jeffery Smith was one of those important people along the way. Take care.
Thanks.
I just wanted to say that in the deconditioning psychotherapy that goes along with understanding emotional conditioning, one of the things that I do is I teach the patient how to self-observe and other observe, how to be more adept at gathering their own data about themselves and other people by learning to observe and keeping their own projections out of the observation, so that they come up with their own clean data to use psychotherapy.
So they're creating the antidote.
Yeah, exactly.
Thank you so much, Dr. Smith. This has been incredible. I really appreciated it.
Well,
do others have comments?
Are you getting a lot of pushback for doing this, or are people pretty agreeable?
No. As you can see, people aren't interested because they don't think that such a thing is possible. At least that's one explanation, or because usually the older ones are quite satisfied with whatever model they have and don't see any reason to go beyond that. But young therapists are eager to have something that allows them to make sense out of all of this and they worry about, if I learn CBT, well, what if will my hair fall out if I try something psychodynamic, and so I think there's a huge need for it, but sadly, amongst the influential people, I have yet to have find as much traction as I'd like, and so I'm plugging away, trying to make people aware of that there is such a thing as a common framework. We did have a breakthrough a few months ago at the SEPI conference when we had a meeting with Greg Henriquez and Marvin Goldfried, who has been calling for consensus for quite a long time. And amazingly, we all agreed. We said, this is great. This is something that's really not that controversial, and we can rally around. So I think there's hope, but there's an amazing amount of apathy.
Does this take the form of, well, I learned this way, and so that's what I know, and that's what I'm practicing, and don't open my mind to anything new?
Absolutely, but that's more for us oldies, except the ones of us who've embraced a more integrative point of view. But I think a lot of the teachers are of the generation that have exactly the attitude that you just described.
I think that the tide may be turning.
Mhm.
I've been sitting in the AdPERT meeting this week, and I've heard a lot of program directors mention integrating. So
Yeah, I mentioned this to a training director, and he said, "Well, but what's the relevance to residents?"
Oh, gosh.
Go figure it out, right?
If people adopt this type of a model, where do you think it leads in the future?
Well, I think it leads to, again, as I said before, I think the key is learning to follow process, not method. And if you're aware that when you're exploring something verbally, that what you're doing is you're allowing the person's old pattern to get activated to the point where it's palpable and they can feel it and there's affect, and at the same time you're trying to foster an awareness that that's not the only point of view, then you're looking at process. You're trying to make a process happen, and to me that is transformative. It's so much more powerful than just saying, well, you're going to look for a maladaptive behavior and a thought that seems to lead to that behavior, and you're going to argue with the thought. Not nearly as powerful.
It sounds like it's like being more eclectic and less rigid about framework.
That's right. And what turns out, as I think, at least that's been my experience over the years, as I've been broader in the range of techniques that I use, and sometimes you'd swear that I'm a CBT therapist, and other times you'd say, "Oh no, this is a psychodynamic person." The more range I've had, the better a therapist I think I've become. And what I find is that I think most of the fear tactics about, oh, you better not mix this with this, or you better not tell patients what to do, or you better not gratify your patient, those things are better looked at like we look at medications, that they have pros and cons, and you need to be aware of any pitfalls that might be involved with a certain way of doing something, and look at the benefits. And so I think that's a much more valuable way to look at the techniques that we use, at our choice of techniques, rather than feeling like, well, all these things belong in one in one school of therapy, and so I better follow that school and not deviate.
Well, thank you for putting all this together. I'm sure it's been a lot of hard work and a long road, but thank you very much. It's very interesting.
Thank you. I'm very glad. Good. Okay, well, let's wind up, and I'm going to say goodbye and thank you all for coming. And if you haven't looked at the infographic, please do take a look. It's if it's not, if you don't already have it on the website, the howtherapyworks.com, there's there's a tab for a store, and the first row of items in the store are free, and the first one of those is that infographic. And also on the infographic, when you have it on your screen, there's a button there, there's a link that will get you to download an ebook that explains these things in more depth and gives a little bit more credit to where they come from, the ideas. So if you're interested, those things are available. They're free. Just remember howtherapyworks.com.
Thank you.
Thank you.
Okay.
Thank you, everyone.
Okay.
Bye.
Thank you all. And thank you, Mary, for being a moderator. I appreciate it.
Oh, my absolute pleasure. Thanks for having me.
Okay. All right. Take
All
care.
right.
Everybody.
Take
All right.
care.
Yep.
Bye-bye.
Bye-bye.